Good afternoon, ladies and gentlemen, and welcome to the 2012 John Ring LaMontagne Memorial Lecture. This lecture, as you know, honors my dear friend and esteemed colleague, Dr. John LaMontagne. John came to the NIAID in 1976, rose to become the director of our Division of Microbiology and Infectious Diseases, and finally served so ably as my deputy director from 1998 until his untimely death in 2004. Today we're very fortunate to have John's wife Elaine here with us to help us pay tribute to his memory, and I extend an especially warm welcome to her. Those of us who knew John remember him as an extraordinarily wonderful human being, as well as a wise and distinguished thought leader in the field of infectious diseases, someone who was always way ahead of his time. He was best known for his work on influenza. John also helped lead efforts to develop vaccines for pertussis, for childhood diarrhea, and pneumonia. He has been such a close friend, ally, and consultant to me, someone who not a major decision was made during the years that he was my deputy that did not involve very intensive conversations with John. And it was for this reason, among many, many others, that we decided that we would have a memorial lecture in his honor. And thus, it is fitting that our speaker today, Dr. Seth Berkley, will discuss the challenges of delivering vaccines for these and other deadly diseases to children in the poorest countries in the world, something that was near and dear to John LaMontagne's heart. Seth is the Chief Executive Officer of the GAVI Alliance, an organization dedicated to saving children's lives and promoting global health by increasing access to immunizations in developing countries. Seth earned a medical degree from Brown University and completed his residency in internal medicine at Beth Israel Hospital in Boston, and subsequently he joined the Epidemiologic Intelligence Service at the CDC and then the Massachusetts Department of Public Health. In 1987, he began working for the Task Force for Child Survival at the Carter Presidential Center, through which he led an epidemiological team in the Ugandan Ministry of Health. The assignment coincided with the emergence of the AIDS pandemic in Uganda, which his team documented through a national serological survey and disease surveillance. This pivotal experience laid the foundation for Seth's later career. Upon returning to the United States in 1989, he joined the Rockefeller Foundation to create and manage international public health programs. And in 1993, a group of health leaders, AIDS activists, vaccinologists approached Seth at the foundation to ask for his help in how we might accelerate international efforts to develop an AIDS vaccine. In response, he launched a series of consultations to identify the obstacles facing the field. And the outcome was a proposal to create a nonprofit public-private partnership dedicated to developing AIDS vaccines. And this led in 1996 to the creation of the International AIDS Vaccine Initiative, or IAVI, for which Seth served as president and CEO for 15 years. And it was in this capacity that I got to know him so well and that we became close friends. Last year, Seth launched a new phase of his career when in August he became the CEO of the GAVI Alliance. Interestingly, John LaMontagne and Seth collaborated on the predecessor of the GAVI Alliance, an organization called the Children's Vaccine Initiative. And I'm sure if John were here today, I'm certain that he would be keen to learn, as we are, what plans Seth has in store for getting the miracle of vaccines to those who need them most. So please join me in welcoming Dr. Seth Berkley.
So I must say I'm incredibly delighted to be here, and thank you, Tony, for that wonderful introduction. Of course, you gave away a little of my punchline, given the important role that John played in this and many of the efforts around vaccinology. And I really wanted to start there because, like many in this audience, John was a friend, a mentor, and in a sense brought the NIH's rigor and science to the field of global health, and became initially started out working in that, interested, but became an unbelievable champion, perhaps more inspired on the global health issues than us working in global health ourselves. So when John passed away too early, it was a huge loss, not just for this science community, but for the global health community. So I'm going to try to take you on rapid sequence through a talk about the area, and it's different than a lot of what you talk about here at NIH, because I'm not going to be talking about basic science. As passionate as I am about the science of vaccinology, this is really about how we take the fruits of that labor and get it to the people who need it. So we're going to start off talking about the greatest need, the power of vaccines, why GAVI, the importance of long-term sustainability, and then some reflections on challenges and opportunities going forward. So starting off on the issue of child mortality, it's really a very exciting time in global health. And the good news has been that there's been a huge reduction in child deaths around the world. We've seen a decline from greater than 12 million deaths in 1990 to 7.6 million in 2010. There's an accelerating rate of decline. So we saw 1.9% a year in the decade before, 2.5% in this last decade. But the bad news, of course, is that 7.6 is 7.6 too many. We're still seeing 21,000 children die each day, and many countries are not on track to reach the UN Millennium Development Goal 4, which is a critical 2/3 reduction in under 5 mortality rate between 1990 and 2015. So where are these deaths? And as you can see, the bulk of these are occurring in sub-Saharan Africa and Southern Asia. And these, of course, are areas that are very important to GAVI, and we'll come back. What are these children dying of? So this is looking at the GAVI eligible countries. So it's that subset of the 73 poorest countries in the world with a gross national income of under $1,500. And you can see that pneumonia and diarrhea are large causes, malaria, obviously a range of other diseases, neonatal causes, and other conditions. And if we look at the infectious diseases causes, you can see that pneumonia and diarrhea account for 24 and 18%. You can see here areas we have other vaccines for, measles, meningitis, and then other conditions that obviously the world needs vaccines for. So let's jump to the power of vaccines. And I think it's an extraordinary history of vaccinology, which I'm not going to talk about in any great depth, but we started a long time ago, and over time we've seen an acceleration of different antigens that exist for infectious diseases. And this is now a collapse of that timeline. And here you can see the cumulative numbers of vaccines that are being developed. Of course, we have even more coming down the pike. The challenge was that these vaccines weren't getting made available to the people who need them the most. And that really is the challenge in front of us. What we know is vaccines can do extraordinary things. This is looking at the results from vaccines on a global basis. And you can see in this time period, this 20-year time period, population increasing 30%, and you can see very large reductions in these major infectious diseases. So a really extraordinary effect on disease burden. One of the great successes, of course, is smallpox, which I don't need to remind this august audience about, but also what's happening right now in polio eradication. So when this was started, it was 1988. There were 125 countries endemic for wild polio, more than 350,000 children paralyzed each year, and you can see that today only 3 countries are still endemic. The really extraordinary change was India, which 3 years ago had the largest number of cases in the world and now has been polio-free for about a year and a half. So we're seeing the power of vaccines in what it's actually doing, and obviously it's critical that this effort get completed. We've also seen dramatic effects on measles, and here is again looking at worldwide measles cases and coverage rates, and a dramatic change since an acceleration of measles vaccine use around the world. But what you can see in this, looking at the African region, is a resurgence. You can see a fourfold increase since 2008. And what's interesting, this is looking at a worldwide map, and you'll see on the lower left flashing a country you'd expect me to show. So the Democratic Republic of the Congo, very, very large outbreak. It says 133,801 cases. You can imagine surveillance is not so good there, so I suspect a much larger number of cases. But just as important, flashing on the upper right, is here's France with close to 16,000 cases. And these cases obviously have been imported in different places. I know there was a big outbreak here in the U.S. and Arizona that was transmitted by a Swiss visitor. Of course, we don't think of Swiss visitors as being people to transmit infectious diseases, but it reminds us the interconnectedness of the world and why we have to pay attention to populations anywhere in the world. So this is a huge problem now being driven in the developing world, obviously, by not using the vaccine that is inexpensive and fantastic, but in the developed world by the vaccine denialists. And this problem Tony and I were talking about before is how do we fight the internet, in essence, and the misinformation that's spreading? Because, of course, it's one thing to have something in a paper or in a newspaper where you can recall it, but it's very hard to do that on the internet. And we're beginning to see now this misinformation spread into the developing world as well from the West, and that's a huge problem. Looking on the ground in other diseases, here's a graph looking at an active surveillance system in Uganda after Haemophilus influenza type B vaccine introduction, and you can see the dramatic effect that's occurring in that community. And here is a slide from Mexico looking at rotavirus diarrhea. And what's interesting here is not only the reduction in the age group that was receiving the vaccine and under 1 year, but you can also see the reduction occurring in older age children. And this was a little bit of a surprising effect because although we expected herd immunity, we didn't expect it to leap into older age groups. This is something that's going to be important to look for as we understand the epidemiology of these diseases in the developing world. An amazing story is what's happened with the meningitis belt. Many of you students of infectious disease know about the meningitis belt in Africa, unexplained epidemics that kind of run through the continent, create not only huge mortality, but amazing morbidity and basic paralysis as many, many people are sick during this period. A candidate vaccine was made. The technology for these vaccines is relatively old, but a vaccine was made specifically for the developing world with a product profile of under 50 cents a dose. It was rolled out, and this is looking at meningitis cases in Burkina Faso, and you can see in the blue column going from 156 documented cases down to 0, the lowest ever seen. A little disturbing, which I'm not going to talk about, but is the next column over where you're seeing W135 cases and an increase in those. And one of the questions is, what do we have to do about, is there going to be serotype replacement in these areas? In the meningitis belt, it was characteristically Meningitis A that was the problem, but it may be that there'll be replacement, and these are some of the research agendas that are required looking in the future. Now, trying to make the case for vaccines, and I think I've shown you the power on diseases, but the U.S. has tried very hard to make an economic case, has shown that you save in healthcare costs, 6 billion treatment costs prevented, less out-of-pocket expenses, less time caring for sick children, and a reduction of $1 billion in productivity loss, longer lifetime productivity, herd immunity we just talked about, and then trade and tourism benefits of fewer infectious disease outbreaks. Interestingly, in the developing world, we also have benefits, but they're not as well documented. And so I'm showing you some real data, but it's very thin, and this is an area that we'd love to see more research in. One is the issue that healthy children do better at school. They have better attendance, they have higher test scores. One study showed a fully immunized child at 11 years of age showed statistically significant increase performance in IQ, language, and math testing. That's powerful information for a development ministry. We talked about out-of-pocket expenses in the West. In the developing world, out-of-pocket expenses are the main way that healthcare is financed. So families tip into poverty. It said that 100 million families a year tip into poverty from catastrophic health expenses. If we could avoid that, that means there's more money to invest in their children. If they're obviously not taking care of sick children, they have less income loss, more productivity. And one critical issue is we obviously live in a world that has a problem with population, and we know that the demographic transition, reducing fertility rates, relates to child mortality. So by having children survive, having parents know that their children will survive and be healthy, means that their fertility rates can come down, which is critical for the planet. Finally, some very interesting early studies from an economist at Harvard, David Bloom, showed that the rate of return for vaccination was between 12 and 18% for traditional vaccines. And if you compare that to primary, secondary, or higher education, it compares favorably. Again, I wouldn't want to rest my hat on these studies, but it's very tantalizing, and we need more research to try to explain, is this true or not? So a lot of good news, a lot of power of vaccines, but of course, today, there are 19 million children that are still missing out from immunization, and you can see in my task in front of me, those in green is the GAVI eligible population of that, and you can see that the single largest country here is India, which has about 40% of the unimmunized kids, and of course India makes most of the vaccine now for the developing world. So this is not a financial issue, this is an issue of trying to get political will, and India is in the process of changing right now and are rolling out pentavalent vaccines in many states. They're looking at enhancing their measles, talking about rubella, so it's an exciting time. And you can see some of the other countries, and you can imagine many of these are quite difficult, the security situation in Nigeria, the situation in Ethiopia, Pakistan, etc. So a very challenging part of the world. Interestingly, when I came to GAVI, I thought that it was mostly going to be an issue of our lower income countries were the ones where the children were being covered, but in the middle income country you wouldn't have GAVI coverage. But it turns out that in fact GAVI is covering almost all of the countries where there are unimmunized kids. So we're talking about 93% of the kids are in GAVI countries, and therefore it is right in the middle of our bullseye to try to do something about it. So why GAVI? What is GAVI? Well, as Tony has already said, GAVI is not the first iteration in trying to do something about vaccines. In 1974, there was the WHO expanded program in immunization. At that moment in time, the immunization rates were less than 10% in the developing world. There were a series of events that occurred, the UNICEF call to try to have universal childhood immunization, the Task Force for Child Survival I used to work for. And in 1990, when there was a declaration of universal childhood immunization, that was 80% coverage. It was probably less. It was probably 75-ish. The world took its eye off that prize, and we saw coverage rates drop. But at that time, a new initiative was launched, and John was very involved with this, the Children's Vaccine Initiative. And this was to try to not only enhance immunization for the developing world, but to have a research agenda to try to make vaccines that were more temperature stable, that were easier to use, that were appropriate for the developing world, inexpensive. And that organization fell apart, not because the vision wasn't good, but because of, I would say, petty politics and jealousies and other issues. And so in 2000, another attempt was made. The GAVI Alliance was launched, and I was involved with that, and as was John. And you've already heard a little bit of what the mission is. 4 major strategies to accelerate the uptake and use of underused and new vaccines, to contribute to strengthening the capacity of integrated health systems to deliver immunization, to increase the predictability of global financing and improve the sustainability of national financing for immunization, and finally to shape vaccine markets. And I'll talk briefly about these 4 goals. So first of all, it's an interesting organizational model. It's actually a partnership working with the major groups that work in immunization. So GAVI doesn't have people on the ground itself. It doesn't duplicate what others are doing. It tries to work with them and bring them in. As you can imagine, this creates some challenges in terms of ability to work together and alignment of mission, but what it means is that you can be very efficient using all of the excellent services that are out there. We have an unusual governance structure in that sitting around the table, the board of GAVI, is all of these critical representative groups, WHO, the World Bank, UNICEF, developing country governments, the vaccine industry, both from the north and the south, civil society, a range of independent individuals, research and technical institutes, donor governments, the Gates Foundation, et cetera. So this serves a couple of functions. It does do governance, but the main function it does is it aligns all of these partners on the goals that are out there and tries to drive them forward, which is quite helpful in terms of working together. GAVI's achieved a lot in its short life. It's immunized over 325 million children with new vaccines, contributing to preventing over 5.5 million future deaths, accelerated vaccine introductions in over 70 countries, has strengthened health systems, and helped shape the vaccine markets. And you can see here the distribution of the diseases that have been affected by GAVI. Over time, as vaccines are shift, we will obviously see a shift in where the diseases are prevented. And this complicated slide looks at where GAVI is working. You can see the geographic distribution of the 73 countries, and the different colors refer to the different vaccines that are being rolled out across these countries. So currently, GAVI supports the Pentavalent vaccine, which is diphtheria, pertussis, and tetanus, hepatitis B, and Haemophilus influenza type B. The Pneumococcal vaccine, rotavirus, Meningitis A, human papillomavirus, rubella, yellow fever, and measles second dose. And we've also done stockpiles for yellow fever and meningitis. We're looking right now at rolling out Japanese encephalitis. We're waiting for a pre-qualification of a more inexpensive live attenuated vaccine, as well as when a conjugated typhoid vaccine is available. We're obviously watching what happens with the malaria RTSS trials, dengue, which is in phase 3, and I'll talk a little bit about IPV as a potentially important agent in the future. So, in a sense, the pentavalent vaccine, which was a novel concept for GAVI, was to bring these together in one injection and roll them out, is pretty much complete. We've gotten it out to most of the countries. It doesn't mean the coverage levels are where they need to be, but the rollouts have actually occurred. If you look at pneumococcal disease burden, this is looking at incidence in children under 5, you can see where the high incidence is, and overlying this in stripes is the GAVI eligible countries. And what you can see here is in colors the countries where pneumococcal vaccine has been introduced, where it's been approved, and there are 12 more countries we forecast between now and 2015 that will receive this. It's interesting because one of the challenges is how quick can we get these out, and the PCV13, the Wyeth vaccine, was rolled out in the developing world about a year after it was introduced in the West, and I'll come back to that later and why that's so important. Here's rotavirus vaccine, similar graph. We forecast 22 more countries other than the ones that are in color here to try to roll those out. Interestingly, for the first time, and this was just a couple of weeks ago, we had a dual rollout of pneumococcal and rotavirus vaccine in Ghana. This was really exciting. It was, you can imagine, complicated in logistically having people trained to do both an oral vaccine and injectable vaccine, worrying about cold chain for both, but a lot of efficiency in doing it, and the Ghanaians were incredibly excited about this, so I was very inspired by what I saw there. So if you look at the traditional trajectory, and here's looking, I could have put any of them up. Here's hepatitis B, and you can see the introduction of hepatitis B in the United States in 1981. You can see a 12-year lag before it first appeared in the low-income countries. You can then see that before GAVI was launched, there was another lag that occurred. You can see the uptick as GAVI moved into the space, a 50% after a 6-year delay in introduction to 50% of the countries, and then you can see here that in fact low-income countries exceeded the percentage of countries getting hepatitis B even over the high-income countries. So this is the goal we're trying to do, is to get rid of this delay that's there and try to get it out where it needs to be right away. And you can see from an equity point of view what's happened here You can see over here in 2000, high-income countries up to 2010, you can see a rise in coverage, and you can see this dramatic increase in low-income countries ultimately exceeding, and here's the same thing for Haemophilus influenza type B. So very exciting. Obviously, I've shown you high-income and low-income. The middle-income countries are beginning to be an issue as we move to more expensive vaccines, and how we're getting them rolled out there is a challenge I think we're going to have to deal with in the future. It isn't only getting vaccines to the countries, though. It's getting out to the people who need them the most. And what you can see here is difference in India between urban, on average, 57%, rural, 36%, and you can see in rich to poor an obvious change here across the different strata. So one of the challenges is how do we make sure there's equity in the distribution of these vaccines. One of the challenges in doing this, and this is relevant to all we do in global health, is the infrastructure in the countries. Now, we invest about 15 to 25% of our income into trying to build health systems for delivery of vaccines, and this is important for all vaccines, including ones that will occur in the future. And health system, immunization is a wedge into the health system. So here you see an immunization clinic being held under a tree, and it's often the only health service that gets out to people. So by strengthening this, you strengthen outreach to the population in a way that isn't true for almost any other intervention. But one of the challenges then is how you build on these interventions. And so we've worked closely with the Global Fund to try to have an integrated platform of health system strengthening to work both on immunization, but also on AIDS, TB, and malaria. This has been slowed down recently by the problems at the Global Fund, but I suspect as the financial situation gets better there, we will be engaged together again on trying to do this. So let's talk a little bit about sustainability, which is also the problem in development aid, is how you make this sustainable. And it's important as we think about vaccine availability, which we all agree is important. There are really three components to sustainability, like a three-legged stool. One is the donor resources that occur, the external resources, and that's what we tend to focus on. But obviously, the price of the vaccine and the country's ability to pay for it and procure it are also important, and these are all things we have to work on. Now, just to take you back to theoretical economic theory, I should say, for all of you who studied this, the concept behind Ramsay pricing is how you most efficiently make things available. And so it used to be that many of the companies looked at this model of trying to provide vaccines in high-income countries, very high prices, very large profit. But it turns out if your goal is to try to maximize your profit, as well as maximize the availability, what you'd rather do is have also serve middle income and lower income, because although you make less profit per dose in these areas, the total profit under the curve is larger. And so in an ideal world, companies would want to do this. And so the challenge for us is to try to move towards Ramsay pricing. Of course, the other thing that happens is if you start increasing the volumes, you drive the cost of goods down, which means that you're actually going to make more money in your primary markets as well. So from an industrial sector, it is good to do this. The challenge is having the political will. And the political will relates to not the South, it relates to the North. How do we tell legislators in the North that we're going to pay hundreds and hundreds of dollars for vaccines that are much more inexpensive? So one of the big breakthroughs was GAVI building a market that was large enough and predictable enough for companies to serve it. And you can see some of the dramatic price reductions that have occurred. Here, looking at pneumococcal conjugate vaccine, you see a 97% price reduction from the prices that are available in the U.S. public market. And this has been a really extraordinary partnership with industry. And so this is going to be critical in terms of long-term sustainability, because as you can imagine, if we were paying this price using donor resources, this would be impossible to sustain over time. So one of the things we do is try to strengthen the market and shape it. And in doing that, we're not just interested in price. I want to emphasize that. And the price reductions that have been seen in the past won't continue to occur as dramatically. What we need is a stable and secure vaccine market. We have to make sure that there's enough money of the companies invested in vaccines to make sure that they have the quality that's needed. And that's absolutely critical for having the world be confident on vaccines. Over the short term, we've seen dramatic price reductions. We've also seen new entrants, and this is important. By bringing developing country manufacturers in, we increase security, because if one manufacturer has a problem, and that could be in the north or south, there are other suppliers to step in. Finally, over the long term, and this is of course where NIH has a critical role to play, is incremental innovation and new and affordable products that can make a difference, including improvements in deliveries and platforms, et cetera. So all of these are issues we're paying attention to in our market shaping. And it's interesting because historically vaccines initially were an interesting thing, and then they became commoditized because they were purchased by governments and they were quite inexpensive, and so there was a huge investment of companies in vaccines. We went from having a large number of vaccine companies to very few. And then it began to change kind of in 1990s with both engagement on the global scene, hepatitis B first, but the really big change was Prevnar, because Prevnar was the first vaccine that became a billion-dollar vaccine. That vaccine today has a market of more than $3 billion a year. Also, the effect of the Gates Foundation, the effect of GAVI, all of this has now made an attractable investment for vaccine companies, which is critical for innovation. And so we think it's a very good time for vaccine companies. However, we also want to see the emerging markets engage. And so you can see that at the beginning of GAVI, most of our supply was coming from industrialized countries. Today, the largest number of suppliers are coming from the developing world, although, as I said, we have had some quality problems in some of our manufacturers in the developing world, probably because the price has been driven down too much. So this is something we have to pay careful attention to. We ask all of our countries to co-finance their vaccines. So this is not a handout. Every country pays. And you can see over time we've had a growth in the number of countries that are co-financing and the amount of money that they've put on the table. This is what the model looks like. In the very poorest countries, they pay a very small amount, 20 cents a dose. As you get into intermediate countries, they pay a higher percentage every year. And then as they graduate, they take on the full cost of vaccines. This is looking at pneumococcal. And what's interesting is if you look at this from a statistical point of view, if you asked the low-income countries to take on this, it would be an overwhelming burden, 6.3% of their national health expenditures. But as countries get wealthier, when they get close to graduation, which is $1,500 gross national income, it actually turns out that they'd have to spend 0.6% of their health budget, the national health budget, on vaccines, which I think we could all agree is a figure that any country should be investing. So the question is not, can countries afford it when they get to that stage? The question is, do countries prioritize the social sector and prioritize vaccines? And so we have an active program to reach out to ministries of finance, which is obviously the critical people, to try to get them to have line items in their budget and to pay an ever-increasing amount of the cost for these vaccines. Let me last move on to some of the challenges and opportunities that are in front of us. So if we look now at the entire world, and this is looking at surviving newborns in 2010, you can see we're doing pretty well on DPT. Hepatitis B is better, Haemophilus influenza better less, but you can see pneumococcal and rotavirus, the two new vaccines that GAVI is focusing on, still are really very low in coverage. And this is where the real push has to be, given the fact that I showed you at the beginning that these are the largest killers in the developing world. So for GAVI, this is the main focus now, is to try to get these vaccines out over the next few years. The polio eradication effort traditionally has not been working that closely with GAVI. I think that's a shame. There's a lot of work we can do together. But one of the things that's being tossed around now is the idea that instead of following a traditional pathway for dealing with the eradication and then elimination of vaccine-derived poliovirus, that what we should be doing is a parallel approach where we not only work on one side towards trying to finish the eradication, but then also try to eliminate the vaccine-induced polio. And if that's to be done, we have to shift probably away from OPV2, going to a bivalent oral polio vaccine, and introduce IPV. And so GAVI is having a discussion. We're waiting to see the SAGE discussions at WHO, but GAVI is looking at how we could do this either as a standalone vaccine or as a hexavalent vaccine. And so this will be an important future direction. One of the interesting things is that there was a summit in last September in New York, the non-communicable disease summits, and I went there and I asked if this was really a misnomer, because what we already know is that a not insignificant percent of the global cancer burden is already caused by known infectious agents, and we already have vaccines at least against two of them, hepatitis B and HPV. I've already shown you a graph that shows that GAVI has moved hepatitis B vaccines out and averted 3.7 million future deaths. And we know that HPV vaccines can protect against at least 70% of the cervical cancer that's out there, which is the second leading cause of cancer deaths among women in the developing world. And so here's a look at cancer caused by infectious diseases, and I suspect that if we were here 10 years from now, I suspect this list would be much longer and we'd see a much larger percentage of causes caused by infections. And so this is an area that we can make a difference across the world. And one of the interesting debates on this is, how do we do this? Do we have to do it with screening? Because many of these countries don't have cancer screening, but this is an opportunity to get vaccines out which are simple to prevent the disease. Obviously, in an ideal world, we have to be able to diagnose and treat as well, but if we can't do that, we still should prevent. This is looking at the developing world, and you can see that in the less developed regions, you're seeing a higher burden of these than in the more developed regions. What we know is that you can have a dramatic effect, and one of the things that was a great success story for GAVI was in China, was engaging with the Chinese government in the west of China and getting hepatitis B in their vaccine regime. And with that, we were able to see them go from very high levels of hepatitis B carriage to very low levels. And as a result of this data, they rolled it out across the country. And at the end, obviously, millions and millions of lives will be saved. So we know we can do this. The challenge is pushing forward. And if you look at the global burden of cervical cancer, the estimate is that there were 530,000 new cases in 2008, 275,000 deaths, most of which 88% in the developing world. And you can see a list here of, or an incidence map of the disease, and on top of that are the GAVI eligible countries. And if you remember this map, if I go back to the previous one, you can see where the GAVI countries are and where the high incidence is. This is a map of vaccine introduction worldwide, and you can see they're almost a complete opposite here of the vaccine isn't getting to where it's needed, where the highest burden of disease is. And so this is the GAVI countries that are listed there, and you can see that that's a terra incognita. So for us, it's an important issue. If we look at the incidence of disease in high-income countries is lower than in low-income countries, but in addition, the mortality is higher in low and middle-income countries. So they have a double whammy of more incidence of disease, but then if you get disease, a higher mortality rate. So this is a huge priority for us, and surprisingly, this has been somewhat controversial in terms of rolling it out, but I think it's something that the board very much wants to see as a priority. Now, from a public health point of view, it has a really interesting possibility, which is we're entering here in adolescent girls, and we traditionally haven't immunized in the developing world in adolescent girls. So alone, this is cost effective at the price we have. But if we were to couple this with family planning, education, safe motherhood information, child nutrition, issues on sexual and reproductive health, a range of potential inputs, it becomes even more effective. But to do that, we have to bridge across different sectors, across the adolescent health sector, cancer sector, women's health sector, reproductive health, HIV prevention, et cetera, et cetera. So this is something we're working on now. Rubella is also a challenge. 112,000 congenital rubella syndrome cases still occurring, 90,000 of them in GAVI-eligible countries. And so our plan is to try to introduce a rubella vaccine along with measles. And this gives you an idea of the millions and millions of doses we're planning on doing with an introduction in 49 countries. And the way this is going to be done is campaigns running across the entire young population up to age 15 to try to reduce the incidence of rubella, not just to try to get to women before they're pregnant. And so this is an ambitious goal. It requires very high coverage rates, obviously, to make sure that you don't have a reinfection that occurs in women before pregnancy. And so countries have to have a sustained rate of measles vaccine of greater than 80% to be eligible to do this. Obviously, there is unfinished business. I've already shown you that there's coverage around traditional EPI that is not as high as it needs to be, the new vaccines that have come out and trying to roll out. And of course, for me, and Tony's already mentioned my past interest in HIV vaccines, clearly we still need vaccines for malaria, TB, and HIV, which once we have them, we'll fall into exactly the same issues we're talking about, which is how you get these vaccines out to the people who need them, and the systems now are in place to be able to do that. I think, interestingly, HPV becomes a real model for what we could do with an HIV vaccine, because it'll allow us to kind of get to people right before the beginning of their sexual activity, and therefore would be the right way to start off. Obviously, we'd eventually like to immunize as a childhood vaccine, but that's going to be a while from now. So in terms of research, GAVI is not a research agency, but we do applied research. And so these are some of the topics we're working on. We're often doing phase 4 type clinical work, real-world effectiveness study, dosing schedules for vaccines that obviously have that done in the West, but not in the developing world. We've done epidemiologic studies looking at serotype replacement. I've mentioned that, impact, herd immunity effects. A little bit on the health economics I showed you and the importance of trying to be able to make the case for immunization and why it's an important investment. And then issues on implementation, vaccine rollout, and system-wide implications. But we rely on agencies like NIH to help us with platforms and new vaccines, as well as new tools. Here's an example of one of the problems that I have. This is looking at Ethiopia. This is a coverage country estimate that is affirmed by WHO. So the estimate here in 2010 was an 86% coverage rate by WHO and UNICEF. You can see here is an estimate from Chris Murray's group at the Institute for Health Metrics and Evaluation, and the Demographic Health Survey supported by the US in 2010, a very, very thorough survey in that country, showed a coverage rate of 36.5%. You don't have to be an epidemiologist to know that this is not a confidence interval problem here or a sampling problem. Question is, what is truth? What we'd like to have is the ability to go in and figure out what is truth. So to do that, we need better data. We need timely data from the developing world. We need to deal with this uncertainty. We need better survey methodology. One area I'm very interested in is biomarkers. Could we do a forensic audit? Could we go in and look at a couple of hundred kids who were in the DHS survey and ask the question, were they vaccinated or not? Well, how do we do that with, for example, third dose of DPT? You know, and so we need better tools for this. We have to take advantage of IT tools and methods, real-time data, new ways to diagnose diseases. So these are all areas that I know NIH is working on and has direct applicability to our public health goals in the developing world. Finally, I want to mention another example of an important technology. Bruce Gellin is sitting in the audience, so he's smiling. Here's an interesting example. So the UN is considering right now a ban on mercury. For obvious reasons, in many industries, this is an important issue. But mercury is used in thimerosal, which is used in preserving vaccines. The WHO and SAGE has recommended that vaccines be exempt. We know that this is a safe preservative. They're essential and irreplaceable. And if this ban would occur, it would really affect our vaccine market. It's not just, well, we could go to single dose because it's more expensive. It isn't a cost issue. It's also a cold chain issue. We wouldn't be able to manage single dose for the entire world, either in cold chain or in transport. So one of the questions is, who's going to invest in trying to create new preservatives that don't have mercury but that could be used? And there's not as much interest as you can imagine in the vaccine industry in doing this, because they worry about jeopardizing their vaccines from regulatory authorities if they were to test them with new preservatives. And of course, the market in the West has gone to single dose for convenience of providers, et cetera. So this is an example of a really important public health research that needs attention. So lastly, let me just say that when I came to GAVI, the world was very much divided. GAVI was seen as new vaccines. There was a measles elimination effort and a polio eradication effort. There were traditional vaccines. There were regional vaccines, R&D. And what we're going to try to do is really come together, not necessarily taking over, not being on others' turf, but how is it we can have synergies? How can we work together? Because when you're doing the polio eradication effort and you're having problems in Pakistan, that's the same place that is having problems in measles, and it's the same place that is having problems with new vaccines as well as existing ones. So how do we as a community work together? And this is an important part of what I'm hoping will occur in the future. So with that, I'll stop, and I'm happy to answer any questions.
Thank you very much, Seth. That was really terrific. Questions or comments? Jim?
With HPV, you've got to get women who are adolescents, and I'm wondering how you're going to be able to get that in the developing world where women fall out of the educational system and seem to be falling out of the educational system even quicker. So how are you going to get access to that particular group?
It's an excellent question, and so first of all, the true answer is we don't yet know, but the way we're dealing with it is before a country can apply for a rollout nationwide, they have to prove that they know how to deliver the vaccine. So there are a few countries that have done some pilot studies, and in those cases they can apply with the data that they have to show they know what they're doing. For other countries, they have to do a pilot. And in that pilot, which we will fund both the vaccine and they're doing the pilot, they will have an opportunity in one district that has both rural and urban populations to show that they can get at least 50% of the population immunized. They can reach them. And then the question is, what is the best mechanism in that country? Is it through schools with supplementals for those that are high risk out of schools? Is it using some type of campaign approach? Are there other approaches that should be done? And so each country is going to have to figure that out. And then with that pilot, then, assuming it's successful, then we will approve a nationwide rollout.
Seth, just on the continuation of that, I was very struck by the extraordinary dichotomy between, in the slide where you showed the global vaccine percentage. Hepatitis B was way over and HPV was here. Even if you factor in the issue of getting adolescent women, you still should have more HPV just on the basis of how good hepatitis B is, because you had to have gotten people to get hepatitis B. Why don't we just give HPV to everybody and get it out of the, I mean, of youngsters the way they're trying to do in the United States, both male and female, to get away from the vaccination of a woman for a sexually transmitted disease? Or does Michelle Bachmann have influence in Africa?
Well, now that I've been asked a politically incorrect answer, I'll answer a politically incorrect. Michelle Bachmann, I want you to know, applied and got Swiss citizenship last week. And then a day later, they reversed it because, of course, they said, well, if you're also a Swiss citizen, you clearly can't be a good American politician. Anyway, that's just an aside. That's a true story. I'm not making that up. The interesting question is, hepatitis B is very inexpensive and has been around for a long time. I was in the original trial. Remember, there was a trial of physicians and men who have sex with men. I was in the physician trial. And so I remember in those days, very expensive. In fact, also, this was the time, and you remember when we later on, it came from pooled serum, and people were worried about this was pre-HIV, and maybe whatever the agent was in there. I remember having a little bit of that fear. So we've seen an amazing production of this vaccine. So now the vaccine is, costs, tens of cents a dose. With HPV, we've seen, again, the huge reduction you've seen. We've now got it down to $5 a dose for the developing world. But at that cost, it is still a very expensive vaccine. And so trying to do what you say would be something perhaps in the future when the price comes down. The other issue is that it's now being used as a 3-dose vaccine. We believe it's likely to be effective as a 2-dose vaccine. And so that's something, those studies are underway. And we'd also love to look at interesting dosing schedules. If we could, for example, give it annually instead of in a tighter schedule, then you would be able to just come once a year, let's say, to schools to do this. My guess is that's not going to work, but these are all things that have to be answered by data. So I suspect, maybe 20 years from now we'll have that same type of coverage, but it's going to be a while.
Bruce?
Seth, one of your pillars is shaping vaccine markets. Talk a little bit about how GAVI is shaping vaccine markets for vaccines that don't yet exist.
So it's interesting, prior to, when I started on this many years ago working, with IAVI and others, there was two groups of the world. There was kind of United States, Europe, Japan, and there was ROW, and that's rest of world. And companies weren't interested in that. I mean, they might give vaccine away, humanitarian reasons, but it wasn't an important market. What's really changed now are a number of things. One is there was initially an assumption that you could charge anything you wanted in the U.S. There'd never be price controls. Nobody would ever worry about cost. And in the developing world, you couldn't count on those markets. People might not be able to pay. And so there was a movement towards going in the Western markets. What's changed now is, one, people are concerned about cost in the West. The birth cohorts have dropped down, and now in the South you've got increased growth rates financially. So that's where the money is now. You've got increased middle-class populations as well, and companies want to be engaged there. So there now is huge interest in those markets. But what GAVI did and changed it is we created a market, a very large market that was reliable for these very poor countries. And so that was a huge effect, because we can tell a manufacturer we'll buy these number of tens of millions of doses, hundreds of millions, and we'll do it over the next 5 years and give them actual projections. So that allows them to scale up and justify to their shareholders, based on Ramsay pricing, that they can still make money and drive their cost down. As you point out, though, the challenge is, what about new vaccines? So one of the innovations in financing, I didn't talk for this audience about innovative financing, which is an important part of GAVI, was to create an advanced market commitment around pneumococcal vaccine. So how do you create a vaccine that's got the strains for the developing world in it and give the incentive to the company to pay back its R&D costs? And so that was an approach where we set up a $1.5 billion pot, of which for every dose of vaccine, the purchase price was $3.50, but we'd pay an additional $3.50 that the company would get and be able to use to amortize its R&D, and that allowed the companies to focus on the vaccines we needed. So that was an innovation that was occurring. We're having discussions now about hexavalent, vaccines, and that's a vaccine that doesn't exist yet for the potential of IPV. And again, the fact that we can come as a large market with a 76 million child birth cohort means that they take it seriously. So those are some of the effects that are occurring in terms of being able to, focus on future markets.
One other question?
Sure.
India puzzled me on one of your slides, because you said India did a good job of bouncing back from the polio issue, and then you showed, I forgot whether it was rotavirus or pneumococcus, that they were red and
Yes.
standing out as a bad job. So what's going on with India where they can be so successful with one and such a failure with the other?
India is filled with complications and paradoxes. I think the most interesting thing in India is that when they focus on doing something, they do it. And I used to joke, if you talk to Bill Foege about this, who of course was responsible for smallpox eradication in India, he said, if we didn't call them off, they'd still be going around and eradicating, in every community. And it's like those soldiers that appear in the Philippines are still fighting the war, 50 years later. So I think India was overwhelmed by the task of trying to provide health care for the entire population, and has been working to improve it, and healthcare has been getting better there. On immunization, the states that you'd expect perform really well. So Kerala, Tamil Nadu, they have very high coverage rates in education and in healthcare as well. Some of the poorer states don't. What's happened now is that India's been emboldened by the success they had in polio. Now they had some vaccine opposition, which is one of the things that held them back from rolling out Pentavalent, but they've had the courage now to step up to the plate and seen that the rollouts are going well. They're seeing their own diseases affected by that, and so they're really excited, and now they want to move on and do more and more, and so the government's engaged. And when that happens, and our role is catalytic, we provide small amounts of funding to get a few districts going. Once they decide to do it, they'll just do it. And so I think we'll see India over the next few years, I hope, being a great success story in immunization.
One question there, Al. Al, why don't you go?
Are you concerned about the long-term susceptibility, sustainability of this approach, the GAVI approach? You're relying on countries to give money. I know recently you had the $3.9 billion given by countries to GAVI in order to pull them out of the deficit. Do you think these deficits will occur 20 years from now as, for example, rotavirus vaccine and Cervical are making those vaccines? They're making it as long as they can make some profit
Well, first of all, we will see a shift there. Right now, India, for example, is making their own rotavirus vaccine, their own pneumococcal vaccines. Those will enter the markets. Those will change dramatically the parameters. China, which up until now has not been an exporter of vaccines, it hasn't had a regulatory system that was approved by WHO, now has one, and we expect very soon the first pre-qualified vaccine. So the market will change. The other interesting thing, though, is unlike, for example, HIV, where for every person you put on treatment, there's 2 new infections still, we have a cap in our birth cohort, and with countries graduating, we're going to see less and less children in that birth cohort. So I would say we're kind of at about the peak. Now, when I say about, if a malaria vaccine appears and it's more expensive, that may drive us up a little bit, but it's not an ever-increasing amount, and over time, the curve will come down given the change in prices. So what we need is, external resources during this period, but countries will take on a bigger share of it, prices will change, and over the long run, the requirement for external resources will go down. So I think it's a sustainable strategy. The other issue is, of course, it's the most cost-effective of all interventions. And so in a world that is spending a lot on global health, this is one that I think measures up pretty well in terms of resource mobilization.
Young lady in the back.
So, what are the kind of creative approaches that you're trying to implement in countries like Pakistan, perhaps, and also comment on what the effect of military
So thank you. For those who couldn't hear, the question was about in places like Pakistan, what type of innovative approaches. It's different in different countries. So, for example, in Afghanistan, the government has asked that NGOs actually do the implementation. So the government requests the money, but then they put it through the NGO sector, who can reach out to areas that perhaps the government isn't doing so well. Pakistan has a somewhat different problem. They have recently decentralized. Now, we consider decentralization a good thing from a management point of view, but they really decentralized. They just got rid of their federal health ministry. It's the only country in the world that doesn't have a national health ministry. And of course, this creates a problem in how you manage the programs. And theoretically, then you'd have to work in each individual state separately. You'd have to understand they'd have their own vaccination schedules, et cetera. We've been able to have the government understand perhaps that this is not the best idea, and so there now is in the Prime Minister's office an immunization focal point that is still doing some of the work, but it is an issue. So we're about to roll out some vaccines in Pakistan, and what we decided to do was to roll out initially in the Punjab, which is more than 50% of the population and is relatively stable and a relatively high performer. With that result, then, we will go national, and in terms of the security areas and higher risk, you have to rely on government, religious institutions, NGOs, and others to try to get it out there. But the ultimate challenge has to be getting into those areas, particularly because, for polio eradication, those are areas that are absolutely critical. And it did not help that there was this campaign, and what she was referring to is the fact that there was a campaign to try to get to bin Laden's family by a doctor going around supposedly giving hepatitis B immunizations, with the idea being that if he got into that compound, he could get, biologic samples that then could be validated as being the bin Laden family. I mean, so far we haven't seen an effect of that I know of, but who knows what's going to happen, and I hope that that will not ever happen again, because we've worked so hard to build the trust of the population and immunization, and once you lose it, it's very hard to get it back. So hopefully that won't happen again. Hi, Bonnie.
Two questions. One is on the cold chain, and you had mentioned about building and leveraging with the cold chain for some of the attenuated vaccines in particular. Is that working well in some countries and not in others? I'm just curious about the workability.
So cold chain continues to be a huge issue, and there is improvement in technology. So we are seeing solar-powered fridges, we're seeing more efficient materials. A lot of the old-fashioned, kerosene-type systems that were good to work in very, very rural areas but weren't very reliable are being replaced now. So I think that's the good news. It still is a problem, and ideally someday We'd like to not have a cold chain. And one of the things that's happening is we now know that there are a lot of these vaccines that actually are stable at room temperature for a while. And there's some discussion about perhaps we want to segregate and allow some vaccines to not be kept as rigorously in the cold chain. Now, the danger of that, of course, is you end up with confusion and you end up having the vaccines that are quite sensitive be destroyed. So people are agonizing about that. It turns out now the biggest problem isn't so much keeping vaccines cold, it's inadvertently freezing vaccines. And so there's a very tight limit between 2 and 8 degrees for most of the vaccines, and trying to, as I said, both get better products but also cold chain systems that are more stable is really important. And for us it's a huge problem because with all these new vaccines, as you can imagine, the volume of cold chain has gone up dramatically.
The second part is on the polio vaccine, where window that you were talking about was just a couple of years. From old epidemiology, I know that the epidemiology of polio is many more years than 2 years to look at an epidemic. What are the long-term plans to be able to follow some of that? Because
Are you talking about the eradication side now, or are you talking about?
for the immunization, I mean, we know from old epidemiology that what happens is you have to have a base population of susceptibles build up. So the question is how effective transferring over to an OPV is going to be during
Yep.
that period of time. So you'll be able to really crack those things.
So there's a couple of problems. So initially they were having problems with getting strong immune responses to some of the strains, which is why they shifted to a 1-3. And as you know, 2 has been eradicated for a while. They had better immune responses with a 1-3. One of the problems is in countries now that have eliminated polio, as we're continuing to work with other countries, they're beginning to have vaccine-induced polio. And of course, when you have thousands of cases of polio, you don't notice a couple of vaccine-induced cases in the middle of that, but then you have no polio, and all of a sudden you've now got most of the cases being vaccine-induced. It's a problem. The third issue in this is that inactivated polio vaccine is a great booster and gives you higher immune responses. So the idea would be, how do we now, as part of finishing the eradication, shift over and use those, but also at the same time try to eliminate some of these vaccine-induced polio strains. Again, this was initially argued at SAGE a couple of months ago. SAGE didn't buy it and have sent them back to get more data. So we presume that it'll be approved, but we don't know that. And part of that is the questions on the epidemiology and how it'll work going forward.
Okay, why don't we end the formal part of it? I usually say, well, come go upstairs and gather for coffee, but thanks to GSA, there's no more coffee. So those who want to come down after and chat with Seth, you can't stay too much longer because you believe you have to catch a plane. But why don't we just end right now? Thank you. Great job. That was great.